Welcome, everyone. Welcome to the HSPN OHT webinar, focused today on population segmentation and how it applies to population health management. Please, as you join, it's been a while since we had these, but let us know who you are by introducing yourself, your name, your organization in the chat. And please set your response to everyone or all attendees and panelists. We want to make sure that we hear from everyone, so please use the chat to check in. Hello, Melissa, Mike. Welcome, Christina Clark. Catherine McCleary, Central Ontario Health Team for Specialized. Welcome. Welcome, Marjorie Conan. Angelica, thank you for joining us today. Hi, Caitlin, Carol Leacock. Nice to see you. Logan Roy, welcome. Senator Fitzpatrick, Buddy, Sharad Huir, welcome from the OMA. Hello, everyone. Welcome to our webinar on population health management and segmentation for population health management. We have 144 joined already, and people will be joining in. Over 300 people signed up today for the webinar in just the last few days. So hopefully we can bring everybody into the conversation today. Wendy from Chatham-Kent, welcome. Welcome, Olivia from CIHI. Rebecca Ho, welcome. Thank you for joining us. Remember to chat to everyone when you're typing your name into the chat. Welcome to our event today. We're really excited. We have a fantastic panel of speakers lined up. And so I think we'll go ahead, continue to introduce yourself in the chat box. Haley Weaver from Guelph, Barbara Frayne from Erie St. Clair, Bernadette Bilodeau, welcome. Hi. Deb Cohen from CIHI. Oh, it's a long time no see, Deb. Nice to see you joining us today. Welcome, everyone, to our webinar. I want to start with our acknowledgement. I'm speaking to you today from the University of Toronto. We don't have quite this decor here at the University of Toronto, but I am speaking from the University of Toronto, and I'd like to acknowledge that the land on which the University of Toronto operates. For thousands of years, it has been the traditional land of Huron-Wendat, the Seneca, and the Mississaugas of Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. And I know many of you are joining us from many territories and lands from across the country. We welcome you to acknowledge the land that you are coming from. So the first thing we always like to start out with is to get everybody a little bit interactive here. And this is going to be a highly interactive event. So first, we're going to start with a little poll, and we'd like to know if you've joined us before. So here we go. Please click in. It's a very simple yes/no answer for those people that have joined us before and those for whom it is your first event. Wow, you're very quick. It used to take us a while to get these, but we now have about 120. We'll just give it a few more seconds here. It's always people on phones, a little bit more difficult. And I will end it off there and share the results out with everyone. So first off, 77% have joined us before. Welcome back. You know what this is about, and I hope you'll be very active and engaging with us today. And for the 23% or 30 or so people among the respondents who said this is your first event, welcome. You're in for a treat today. You've joined us on a really great event. So really happy to have you with us. And we're going to come off and introduce today's session. And so if I can move the slides along, first a little bit of an overview, some key takeaways from today. And then we're going to have the CIHI Population Health Grouper, some introduction to how CIHI has developed their grouper. Then from British Columbia, we're going to hear about how segmentation is being used in British Columbia. So looking forward to that. Then locally with supports for Ontario Health Teams, what's the frontline use of segmentation and how does it look? And what are the challenges that Ontario Health Teams are facing from some of the coaches that are helping with population health management? And finally, hearing from OHTs, some insights from providers, patients, and caregivers for population segmentation and co-design. We have an all-star panel. I'll serve as host. Very, very happy that we have Debra Chen, With us, she leads the population grouping methodology of the POP Grouper team at CIHI and responsible for the maintenance and enhancement of the POP Grouper. And Debra is the expert in this. Absolutely so pleased that Debra could join us today. Samantha Magnus is Director of Methodologies and Cross-Sector Analysis Team in the Health Sector Information Analysis and Reporting Division, the BC Ministry of Health. And Sam's been using segmentation to support BC. She sits on the Canadian Institute for Health Information's Case Mix Advisory Group, so Debra's advisory, and has several experience in both qualitative and quantitative research. Sam's going to lead us through some awesome examples. Rob Reid, many of you know very well, so I'll be very brief. He's the inaugural Hazel McCallion Research Chair in Learning Health Systems at the Institute for Better Health, Trillium Health Partners, where Rob and I are co-conspirators in some work. And he's a lead for the coaching team along with Mike Hindmarsh. Christina Southey is an independent consultant and a coach. And she's worked with clients in Canada, the US, and internationally as an improvement advisor, supporting numerous projects in the primary community realm, including initiatives focused on COPD, depression, access, deprescribing, dementia, among others. Christina's very experienced and she's an awesome coach. We're gonna have Curtis Hanfield then speak with us. And he's a family medicine practitioner. He's a primary care doc at the St. Michael's Hospital Academic Family Health Team. And he's been involved many years there in teaching and scholarship. And since 2020, he's been the co-lead for the Downtown East Toronto Family Health Physician Network, as well as co-chair for the Downtown East Ontario Health Team, Mental Health and Addiction Year 1 Population Working Group. And he's going to speak to us from his experience with that. And finally, Alex Smith is going to join us, and he's the process design and change management lead at London Health Science Centre and an operational team member for the Western or Middlesex London Ontario Health Team, where he focuses on co-designing patient care pathways for system transformation. And if you are not excited yet, wait till you hear them talk. I'm going to lead off with a little bit of an intro for a few slides. And I want to say that we're building today on prior work that we've done. And back in February 2021, we had a webinar on population health management, and these were the folks that presented on that day. And we went through a bit of a review of population health management generally, and then specifically around segmentation. And so we're building on that work today. And if you want some background review, I recommend that you go back and review that webinar. In that event, we covered a few pieces. One was defining population health management. And just so we're all on the same page for today, we think of this as the concept of gathering data and insights about population health and well-being across multiple care and service settings with the aim of identifying the main health and social needs of the community and adapting services accordingly. So it's reaching out, it's understanding need, and then it's using it to design care. We had introduced the Population Health Alliance Population Health Management Approach, and it has 6 basic steps to it. One is population identification. Then there's a health assessment, which leads to a quadruple aim assessment. Then we think about risk stratification or population segmentation, the focus for today. And then that has to lead, that has to be useful. It has to lead to patient-centered interventions, impact evaluation, and then a whole quality improvement process. So this is just one step among many that OHTs will need to continue with. You know, the archetype for risk segmentation is this Kaiser pyramid. I think most people have seen this image or some version thereof. And you can think about this as, you know, what are the different types of care that are required depending on the risk of the population. So up at the top, patients with severe complications, they're going to need some pretty serious case management, particularly if they're encountering many different providers in the health system and health and social systems. And you have in the high-risk patients, some of them are going to be more self-managing, but some are going to need some of that professional care as well. You see here more self-care kicking in. And then we have people with chronic illness where we really need to support self-management. And finally, in the mostly well population, which you might think of as a general population, you're focused on promotion and prevention. So these different levels. And we've seen this a number of ways. Rob's going to talk through a little bit about how they're using this in RISE. And so you could think they're different populations. So institutionalized seniors, they'd be near the top of that peak. People with substance abuse or mental health issues, they're going to cross a number of the different levels depending on their own needs. So this is the idea of, even once you have your overall population identified, even within subpopulations, there are people with different risk profiles. And that's going to be part of our key takeaway today. Back in February, we talked about how Denver Health was using population. So on the left there, you see there's their risk pyramid for adults and pediatrics, the different tiers. And then they actually have budgets set for baseline budgets that they allocate across the tiers with different amounts. And they use that to pay for staff. So they have different teams. So very multidisciplinary, high-risk health team at the top, and just basically health information technology and digital support often, with some primary care at the bottom, or e-touch management. And you see also the tools that they provide on the far right side. So they're using that pyramid to set budgets, work on teams, and support patients in the community depending on what their needs are. I think that's a really key piece to this. When we describe population segments, and this is a pretty crude picture, and both Debra and Sam have much prettier pictures of this in a few slides. The idea being that you have data input, predictive and descriptive, and then you have a bouquet of flowers. You gather all the information about your population, and you also think about what the patient needs are for those different flowers. And you're going to want to break them up into different types of flowers that need different care, and maybe different light, different water, different care packages in the real system for healthcare. And that then leads to that frontline approach to service delivery design for those segments. So some of the key takeaways we had was that population health management is multifaceted and complex. It requires both having an abstract macro view of the health needs of an entire population, possibly geographically or otherwise defined, but then you also need micro precision implementation of appropriate interventions to meet the needs of the segments of the population with differential needs and risks. And from our view, population health assessment and segmentation is an essential step to enable pop health management. And Ontario Health Teams, focus audience for us very often in these events, mostly, are building population health management capabilities. And over time, they'll be applied to different segments and populations. So that's, we don't expect everybody to have everything in place already. It's a building process, and we're trying to provide some support towards that. One final thing I'll say before we really get into the great action here is that there are many ways to segment a population. And I'll say there's possibly more useful and less useful, but there's no single perfect way to do this. And some form of segmentation is better than none. Segmentation is all about ensuring that the right care is delivered to the right population, and ideally that's suited to their risk and needs. We need to think about segmentation at the population level, and that's at the level of the attributable population, but we also need to think about risk segmentation within focused populations. So people with different levels of mental health needs, for example. And finally, and brought to life today from our OHT presenters, there are multiple sources of data to understand population health needs. It's not all about having just population health administrative data that creates some segments. You also need to really understand locally what the stories are, what people are telling you, what providers are telling you. And so we'll bring that to bear along the way. So just as we get started here, I have one more poll. I'm interested in knowing how familiar you are as an audience in using population and segmentation and or risk stratification for populations. So let me launch this poll. And here we go. So let us know, do you understand and can use this data well? Understand the concepts but haven't tried it? Trying to wrap your head around it. Is it very new? Segmentation stratification, does that happen when I melt chocolate in the microwave? And I tell you this because my daughter, the 12-year-old daughter, was making macaron this week, and she was trying out it was a strawberry macaron with a white chocolate filling, And instead of just doing that slow cook melt over the stove, tried to do the speedy chase in the microwave. And don't do that. It doesn't work. Just stratifies. So here we go. We have about coming up to 140. We have over 200 people online now. So welcome everybody. Really, you're going to be in for a treat. Okay, I'm going to cut this off and show us up our results. And we have people at every stage of understanding and knowledge today. Yes, some people, most people, understand the concepts, but I think we have a lot of people that this is still fairly new to. So for the speakers, keep that in mind as we go through. Oh, there. Oops, I forgot to share the results. I was looking at them, reading them. So there you can see the results and knowing that people are distributed across. Okay, well, thank you very much. Those are my introductory comments. And without further ado, I look forward now to Debra Chen, who's going to lead us for understanding CIHI's pop grouper. Welcome, Debra.
Thank you, Walter, for the nice introduction. Hi, everyone. I'm Debra Chen from CIHI. Just listening to Walter's introduction and also the messages about population segmentation. So CIHI's population grouping methodology, or pop grouper, is one of the probably multiple existing grouping methodologies that can do the job. So I'm going to provide a very quick overview of the CIHI pop grouper. Okay, so what is pop grouper? I have two screens, so if you wonder I'm not, why I'm not looking at you, that's why. So what is the pop grouper and what does the pop grouper do? So in short, the pop grouper is a grouping methodology that sorts the entire population into groups in which the subpopulations have similar clinical characteristics and very similar the healthcare resource requirements. And the grouper is person-focused, but can be applied to the entire population, even including those very healthy persons who never interacted with the health system or never had a diagnosis. It's also beyond a specific sector of the health system to help us understand the holistic healthcare needs of the population. Next slide, please. Okay, so in order to sort people into groups, the pop grouper first needs to create individual clinical profiles using multiple data sources, including person-level data on hospital care, ambulatory care, residential, and community care. That's the input side of this picture that you are looking at. And on the output side, the clinical profiles include information on health conditions, like a person's health conditions, and their dominant health condition that drives a person's health care. And for those clients with long-term care and home care data, the profile also includes their functional status information, such as ADL. And in addition to the clinical profiles, the pop grouper also outputs a list of predictive indicators to predict healthcare costs, number of ED and physician visits, probability of admitting to long-term care for those 65 years old or older, and the risk of hospitalization for COVID-19 in light of the pandemic. Next. Thank you. There are lots of details in the grouping methodology. Without overwhelming you with too many methodological notes or details. In a nutshell, the grouper starts with a person's diagnosis. The grouper maps tens of thousands of diagnoses to a manageable 226 health conditions. And since a person could have multiple health conditions, in order to identify the one that's best represents their cost and the clinical profile, the grouper rolls up the 226 health conditions into 164 health branches. And in each branch, the health conditions are clinically similar and require similar cost resources. And then each of the 164 branches is ranked from the most clinically complex and resource intensive to the least. And then depends on the comorbidities. The branch can be split into conditions with or without significant comorbidities. And after the split, we end up having 239 health profile groups or HPGs, which represent a person's most clinically relevant and resource intensive condition. And the 164 branches can also roll up to 16 broad categories that summarize health condition by type and severity at a higher level. Thank you. To show you how the grouper works, I'm going to use a fictitious person, Mary. Mary is 60 years old, and in the last 2 years, she visited her family physician multiple times. As her condition declined, she was admitted to a nursing home, and at the nursing home, she fell and broke her femur. So she was admitted to a hospital. Through her interaction with the health system, multiple diagnoses were identified for Mary, including migraine, diabetes, hypertension, and multiple open fractures of femur. And these diagnoses get mapped to corresponding POP health conditions, as you can see in this diagram. One thing to note is that, as I mentioned earlier, the population grouping methodology can be applied to the entire population. And we know the population also includes healthy persons as well. So an individual in the POP grouper could have 0 to many health conditions. Okay, next one. Thank you. The health conditions provide very rich details to explore multi-morbidity, comorbidities, and a client's complex care needs. But sometimes we just wanted to summarize the overall health of a person in a simpler way. So we need something to help us identify the most complex and clinically relevant health condition that drives a person's clinical profile. So in order to figure out Mary's dominant health condition that drives her care, all her health conditions are rolled up to 4 health branches. In that table, you can see 4 branches. As I mentioned earlier, each branch is ranked according to resource requirements and clinical complexity. And the highest ranked branch, major acute musculoskeletal or MSK, was assigned to Mary because that one best represents her clinical and cost profile. And since Mary also has a moderate acute condition, which qualifies as a significant comorbidity, so the health profile group or HPG or dominant condition, major acute MSK with significant comorbidity was assigned to Mary. From this example, you can see a person could have multiple health conditions, but can only have, one HPG or one dominant condition in the grouper. Next one. Thank you. And the grouper can roll up health conditions into 16 broad categories, as you can see in this list, and just to allow users to analyze the data at a higher level. So yeah, the grouper can drill down or roll up to a level most meaningful to the users, all depends on their analysis. And generally speaking, the higher the rank in this list, the more clinically complex or resource demanding. So based on the health branch assigned to Mary, she ended up in the major acute category. So that's the end of the POP grouper classification. That's the highest level of classification in the POP grouper. Next one. The PopGrouper also creates clinical profiles from the cost perspective to help us understand a person's resource utilization. In the grouper, each health condition is associated with a relative measure of cost, which is called cost weight. The methodology is very complicated, but anyway, each health condition is associated with a cost weight. This table outlines various health conditions and associated cost weights for 2 time periods. The 2-year look-back window in which her health conditions were identified, and a year into the future. And for each time period, you just simply add the numbers up to get the total cost weights for a person. So in this example, after the calculation, after I added up all the numbers in the 1 year into future column, I got 1.71. And since the reference value or anchor value for Ontario is a scale to 1, it's very intuitive to compare resource requirements against the provincial average. So in this case, treating a person with a clinical profile similar to Mary's would cost 71% more than treating an average person in the population in this province. Okay, next one. Thank you. In the grouper, clients can move from one health category to another. All depends on the change to their diagnosis. Douglas is Mary's younger brother, who initially had 4 health conditions and was in the moderate chronic category, but later on, an additional diagnosis, stroke, was found, and that moves Douglas from moderate chronic to major acute category, which means he's now much more clinically complex and resource intensive, and his care needs, of course, also changed. So from this example, you can also see that more data you have, more complete and accurate clinical profiles can you build to understand your population's care needs. There are lots of methodological or technical details in the methodology, and also lots of components in the methodology. So in this overview, I kind of selected only those components I think most relevant to today's conversation. So there are lots of more details. If you're interested, please reach out to me. I'm very happy to explain more and also provide more information. And in terms of, the PopGrouper in action, there's a widespread use of the PopGrouper across Canada. And currently, there are 9 jurisdictions that have access to the CIHI PopGrouper. Ontario, Alberta, and BC probably are the biggest users among all the 9. And in Ontario, as I know, Ministry of Health grouped multiple years of POP outputs to support OHT implementation, and also for primary care capacity planning. And Alberta Health Services grouped 18 years of their data to monitor disease prevalence, cost variation, and health service utilization by population type, or you can call it segmented, population. And the BC Ministry, I think Sam will be talking about some cool examples, how they use a CIHI PopGrouper to support their analytical work. So I'm not going to get into all the details. So other jurisdictions, either they are using the grouper or exploring the grouper for their future projects. I think that's all I have for today. I know we have time allocated for questions. I'm really looking forward to your comments and questions.
Thank you so much, Deborah, for distilling an incredibly complex methodology that took years into 7 or 8 minutes of a quick high-level overview. And I'll say the complexity is not lost, but also some questions coming up are also fairly advanced. So we're going to come back to some of those, but I invite you, Deborah, to have a look in the chat box. Sam's been answering into a few of them and I've commented, but we'll come back to some of these in the discussion again with the audience right after Sam's review. Sam, the floor is yours.
Thank you, and wonderful questions. I love seeing these questions, and I'm going to have to pause typing back for a moment. Next slide. I do want to acknowledge as well the land that I'm standing on, the land of the Wasanich people here in BC, especially it being our first week of having a National Day of Reconciliation. Next slide. So why do we categorize people and patients? Next slide. I always think of it as putting people in boxes. So I'm going to give you a bit of a metaphor to think about the population grouping methodology and the pop segmentation that we use here in BC. Next slide. But in essence, the population grouping methodology, as Deborah said, it's patient focused. You can read all these bullets later. In BC, we also use the health system matrix, which on the next slide, which summarizes not just all those diagnosis codes and the health conditions and health profile groups for each patient, but what their health system usage was over that year. And the matrix uses a combination of chronic disease information, which is from the registries, from the Public Health Agency of Canada definitions, as well as actual thresholds of healthcare use from different sectors or different types of healthcare use to categorize people into population segments. So in BC, we have population groups and population segments. And the great thing about the matrix is because it summarizes healthcare use over time from all the different parts of the health system that we track through administrative records, we can develop specific indicators for each part of the health system if we wish. So I'll just forward on to the next slide here. So I think of the health conditions as tags. Each person in the population can get multiple tags. We made a custom one for death because there's a newborn health condition. That's why we have one more in BC than standard from CIHI. The health profile groups are the boxes, and the health profile group categories, I think of palettes. So similarly themed boxes all together. Population segments has a symbol, in BC has a similar number of groups to the categories. We have 14. And again, that's based on thresholds of health system use, as well as chronic disease information that is lifetime rather than the 2-year window. So it's a different lens into the population. Next slide. So we have a number of different applications. I'll be going into one shortly, but they can be used at different levels of granularity, from a physician practice to looking at the provincial health status. Next slide. So here's an example of just taking one of those health conditions and plotting it on a map. And we can see radically different 2-year prevalence of health condition use for just one condition. If we did this with a chronic disease registry, we'd see much higher rates, but this gives a narrower window into time using CIHI's 2-year look back for health conditions. So next slide, please. And here's an example of using those health profile groups. And there's a few of these bars are labeled. On the left, we have population size for different health profile groups. And on the right, from the matrix, some cost estimates at the per person level for people on average in a health profile group. So that gives you that picture of some of the conditions like extremely low birth weight. It's a very expensive health profile group to be in, but it's very rare. Whereas another one like dementia with significant comorbidities, that's a very expensive health profile group to be in, and has a large number of persons in that group. So on the next slide, this is a similar kind of graph, but looking at that health profile group category level. So the 16 groups from CIHI. And on the y-axis here, again, it's average cost per patient, and on the x-axis population. And so you get that picture of palliative, people in the palliative category, very expensive per person, but small population, whereas the minor acute health profile group, very low cost per person, but a huge proportion of the population falls into that category. And there's kind of an inset there that you could take some time to look at later. I don't want to spend too much time on it because I want to get into the next example. So next slide, please. Population segments, this is what they look like. So similarly, on the left here, we have the share of the BC population, and we have a population segment that we call healthy. That's just based on having less than a certain threshold of estimated healthcare dollars spent in a year and having no other chronic diseases or mental health hospitalizations or palliative care or something that we would use to put it in a higher ranked population segment. Whereas on the right-hand side, if you look at the cost share of each population segment, seniors in residential care, high chronic conditions, these are more prominent. And I know there was a question about frailty in the health system matrix. We have a very simple frailty definition that's just based on home care use. So it's not really representing clinical frailty. It's more receiving services for frailty in the home. All right, next slide, please. So I want to launch into a bit of an example of how we use population grouping methodology to create our own COVID risk scores. Debra talked about it being an output of what CIHI is offering out of the box with their methodology, but in BC, we trained it on our own data, and we retrain it every 2 weeks to have different risk scores for COVID. So next slide. For the data sources that we use our client demographics from our provincial health plan enrollment. We need to be a little tricky to identify long-term care patients. We need to look at pharmacare plans as well as long-term care administrative records because of the way long-term care is administered here in BC. There were some questions earlier about socioeconomic status, so that's something that we assign at the person level, at least for area-based indicators based on the census. Sometimes it's possible to get other indicators, but that's the data sources we use. So next slide. And we took those health conditions, and CIHI did an early literature review at the beginning of the pandemic on which health conditions were most likely to pose a risk of hospitalization for COVID patients. So some of them we grouped into these 15, we call them at-risk health conditions. Next slide. And then we basically put them into a logistic regression. My slide got a little bit garbled here, but in a nutshell, we kept all of the significant health conditions on BC data, and using the different coefficients from the logistic regression model, we could apply for everyone in BC based on the conditions that they had. And this slide doesn't show age, which of course is a significant factor. So based on their age and their conditions, using that regression equation, we could produce a risk probability of hospitalization should they contract COVID. So on the next slide, we actually went and applied that at an aggregate level to all the health regions of BC. And so the map that we ended up generating, it does show you closely, because COVID affects different age groups. It does closely match where the most elderly populations are in BC, but also adjusting for the prevalence of different health conditions through the pop grouper that are at risk. We're able to say, all else being equal, these are the areas that we would be the most concerned about in terms of a high proportion of hospitalizations from COVID cases. So on the next slide, oh yeah, I don't have a next slide. But what we then did is for every day, the cohort of COVID patients that we get the PHN score, we apply that same algorithm and say, what's the probability that, the 500 or what have you new COVID cases that they are going to end up in the hospital. And we join that with our hospital teams data on hospital capacity to develop a very short-term alert system for those patients that don't discover they have COVID at the hospital, how likely they are to end up in hospital, and what could a very short-term capacity issue be. So that's an example of using the health conditions from Pop Grouper to a very specific use in creating these risk scores. So something similar could be done for different population groups and different kinds of care focuses. So on the last slide here, I just wanted to quickly acknowledge my team. The last time we ran through some of these slides, Yankai Leo, one of the senior economists on my team was beside me. Some of these other names, if you've worked with us before, you might recognize. And of course, my executive director and my ADM. I tried to whip through that fast. There you go.
You did, and I don't think I cut a slide out of you. So I think that I know that there was more material that you had to cover, and you might have a recording online for some more detailed that you did previously for BC Pop Health. Thanks, Sam. So we're going to open it up now, so Deborah, you might join back in and see how the chat goes. I have a poll. So how important do you think, for audience, it is to use population segmentation to plan and implement care for the Ontario Health Team populations? So let me come out and launch this. And yes, you can see it now. So allow you to opt in and think about what your sort of positionality or your how you're feeling about segmentation. We're coming in a little over 100. Leave it open for a little bit longer. It's just a bit of a bellwether on how people are feeling about segmentation. And it might stem from a little bit of your capability and capacity to do it as well. Okay, I'm going to end it off, and this time I'm going to share the results as well. So here we are. The most common was that it's critical to the work, and then others are important but not essential and could be useful. And then a few rare people are thinking it's a bit of a distraction. That might be because of the present access to data or otherwise, and a few people unsure. But we do see that there is some value to this, and we're going to continue to try to provide practical examples for how it can be valuable and useful. So we're going to come back maybe to one or two discussion points. I want to prompt one discussion in the chat. And that's, I say people come for the content and stay for the chat. And that's also to get a bit of a sense of how other people are working on segmentation within their Ontario Health teams. So we're interested in knowing what approaches and tools are you using to identify priority populations or to undertake any form of segmentation. So interested to know. So let's just leave it out there and let a few people come in. Meantime, I'm going to come down off the share and we can see each other. So Sam, I'm going to ask you to come back on the video, and let's just open it up a little bit. And I think I can get rid of the poll on the screen there. Thanks, welcome. So I'm looking here at one of the questions that came up previously, and I said we'd bring it back up in the chat, was there were some questions about underlying health conditions that people have that somewhere downstream end up causing more health challenges. So somebody may have like an underlying mental health illness and that later on causes an accident. Or people may have underlying cardiovascular risk conditions like a hypertension or something, which in itself is not a big deal, but maybe in a year or two. Are these addressed at all in the segmentation approaches? That's an open question for both Deb and Sam to think about.
So in the CIHI pop grouper, by default, we have the 2-year look back window. So why 2 year, not like 5 years or like 1 year or anyway, because, when we developed the methodology, we figured out 2 year would be a good, like a length of period that allow you to identify chronic disease and also some acute conditions, but not too long that, like you go back, too further, like in the past to identify a bunch of old acute conditions that might have, too much influence on your predicted, like a healthcare costs in the future or the future, health services usage. But in that 2 year window, like you said, like mental health, if like you have a diagnosis that mental health condition will be flagged, and also if you have any conditions like medical conditions caused by mental health or addictions, and that would be captured as well. And in the pop grouper, that person, you would see those things all presentable or available in that 2-year window to build the clinical profile. I don't know if that answers your question, but
yeah, I think it's straight. You at CIHI struck the balance, and that's how you struck your balance.
Exactly.
We did experiment with using a larger window for pop grouper, and we found all these funny phenomenon, like suddenly the proportion of people who are pregnant. Because if you extend it too much, and that's a pretty high intensity health condition, usually involves a hospitalization, and it's in all kinds of different healthcare needs. And so if you extend the window too much, it kind of warps the health profiles a little bit in a way that becomes less useful.
Yeah, that's a really useful response, I think, because there's a balance in these of both chronic and acute conditions, and thinking about those and how long that acute condition will last for. Sharada Weir from OMA, they've written a few papers on the CIHI grouper that are published, and she noted that in the chronic conditions, they actually found the longer look back was a little better. And I think that's because people aren't always seeing the healthcare system for a related condition. Sometimes other conditions are more prevalent and common. The other question that came up earlier in the chat was around social determinants of health. And these are complexity groupers around healthcare use. And I think many of us are aware that long-term social deprivation and other conditions, race, others, contribute to differences in access to care and long-run health outcomes. Are any of those built in or addressed in any way in any of the groupers you've seen? So the CIHI, the BC, or any others that you might be aware of. There's Hopkins, there are other groupers.
Yeah, currently in the CIHI grouper, it's very clinically, focused. And you can see mostly, the health conditions are based on the diagnosis. And but now CIHI has access to the EMR data provided by the Ontario community health centers for primary care services. And in that data set, there's social determinants of health variables. So we are trying and exploring the feasibility to incorporate that data set into the pop grouper. And also we are going to assess how the social determinants of health variables in that setting or sector impact the pop grouper, the people's clinical profiles, and also the predicted indicators like cost weights. So we are working on it, although now we don't have the results available.
Yeah, Sam, have you seen any work done?
I mean, we do. We've done our own analysis looking at area-based indicators of socioeconomic status and cross-reference that against the pop grouper, and it's as you'd expect, right? Some conditions are really common. We actually did a geographic analysis that looked at clustering of diseases in the province, and then cross-reference that against area-based measures of social deprivation. And so there's some conditions that are extremely clustered in more deprived communities. So I think I appreciate that pop grouper is more strictly on the clinical side, because then you can do these complementary analyses and have them as independent variables in your analysis. And so it's important, and it could be layered. It could be layered into single models of trying to determine risk for sure.
Yeah, I'm just going to close off now with a couple comments coming in from the chat. Margot Cameron, thanks. In our mental health and addictions organizations, using the level of care utilization system, or LOCUS, to evaluate our entire population of clients and make decisions to match clients with the right intensity of clinical service. That's exactly the right example, and that's a different data set in the mental health population. Margot also notes one of the challenges is funding to expand human resource capacity for decision and data support roles as expectations for data analysis and interpretations increase. And that was also echoed a little bit earlier. And I'm trying to come back to the comment around really a challenge, a lot of good chat. A real challenge, though, it was mentioned previously in the chat around just finding the human resources and that technical capability. And there was a comment around needing a really one full-time person who can really dive in and understand this and help. Long run, that may be true. And just doing it off the corner of a desk of someone who also has other activities to do is probably going to be challenging to take full advantage and benefit. And I think a more advanced systems, and as OHTs progress and advance, building that capabilities, I think, and supporting it will be really important. And the final comment I'll bring just before we move on is from Alan Katz. Really appreciate this being interesting to describe a preferred state scenario where CIHI's pop grouper can be applied and integrated with other data sets accessible to OHTs to help with local decision making. And I think that that's where we want to get to, right? And even I think that's an excellent comment. And I know I'm thinking a fair bit about that. I know Rob's thinking a fair bit about that, and others in the province. I want to thank you, Sam and Debra. Don't go away. There might be other chat, and I really appreciate if you continue to respond into some of those chat questions. It's very, very helpful. And you can see that we have a very engaged audience, over 200 people, and they are dialed in because this is very interesting. Thanks for taking the time. And I see that Rob and Christina have joined us, and I'm going to bring up their presentation. And so I'll turn it over to you, Rob and Christina.
Sure, Walter. It's wonderful to be here from RISE. And for those that don't know, RISE is another platform, a learning platform to help OHTs around their journeys. And we work together a lot with HSPN around helping OHTs discover the path around population health management. I'm one of the co-leads, and I'm going to be very quick today because I really want you to hear from Christina, who's one of the coaches who works one-on-one with OHTs across our region around helping them develop strategies on all things population health management, including segmentation. And Christina has some observations that I think are really important. So let's go to the next slide, Walter. I just wanted to say before I started how wonderful it is to hear from Sam and Debra. I started my career in population grouping tools many, many years ago, and it's really lovely to see the sophistication that these tools have developed right here in Canada for our application. Remember that grouping tools have many different applications. We've heard a bunch of them today. We've heard about their use in public health purposes to understand and monitor the health of the population. We've heard about planning. We've heard about resource allocation, evaluation. But the one that we're talking about today is really around population health management, around really directing care for populations. This is the first slide, and these are RISE slides. Many of you have seen them many times before, but I just wanted to anchor on this slide. OHTs are oriented around attributed populations. And the main thing here is this is the first key step in population identification. It is the identification of the entire population that you're accountable for. That includes everybody across the spectrum. So we have to make sure that we have ability to identify the entire population so that we don't leave people behind. And another point on this is to remember that populations are dynamic, that they change constantly, so that those population definitions have to constantly change as we see births, immigration, mobility, choice, and so forth. So just remember how important it is around the definition of the population before we start with the segmentation approach. Next slide, Walter. So this is the 3 populations that most OHTs are thinking about or working on as their priority populations, with the view that they will move into other populations and extend across their entire attributable population over several years. So really many are focusing on palliative care approach, people with mental health and addictions issues, and an older adults with greater levels of chronic illness. And as you can see, both this CIHI grouper and the BC Health Matrix now have the ability to start segmentating the overall population, but also the populations within these large segments, so that they are getting to the fact that progressing to segmentation. Okay, the next slide. So this is a RISE slide again, and it's just the Kaiser risk pyramid. And it's mainly to remember that we are responsible for the entire population. And over time, we need to make sure that we have programs and abilities to manage proactively care across the entire population. So we have to have ability to segment and identify which people fall into what box, as Sam so well talked about. The next slide. And then remember that, oh, actually, can we go back, Walter? Sorry. So remember that in addition to measuring illness burden, we also have to measure health risks, barriers, and complexity as it goes up the pyramid. And because that relates to the care management and coordination needs and how we actually deliver care. Okay, the next slide. And this is just an example of how you might apply population-based thinking and segmentation tools in a population of chronic illness patients who you're actually now wanting to interlay mental health or depression care for. So when you segment for patients with chronic illness conditions only, this might be actually where you start screening for depression. When they have mild or moderate depression, this is where you might have treatment in primary care, watchful waiting, medication, CBT, online. Severe and more complex mental illness and depression clearly needs to have additional resources built in. And the last bit of this is just remember that we do need to measure socioeconomic status and barriers to care, so that we can tailor our interventions to address those issues. So I'm going to leave it at that right now, and I'm going to hand it over to Christina, who will really now just talk through her perspectives of what's happening in OHTs. Christina.
Thanks, Rob. And I have to say the chat today has been really interesting. It's basically as an example of what we get to experience as coaches, and the questions and the observations that members of the OHTs have, and you see them in the chat. And what it really highlights is the overall theme of what we see is that OHTs are in very different spaces. And the way that each OHT has thought about segmentation and applied it is a little bit different based on their priority populations, based on the resources they have, and the length of time that they've been together. So I would say for the comments that and questions that I have today, to recognize that it's a little bit different for every group and based on the work that they're doing. But in general, there are 3 sort of overarching themes that we have seen over the last couple of months. The first is being able to look at holding onto the tension and where to go based on the data that's coming around the attributed population, and how to match that up with data from other sources. So for example, I was sitting with a team yesterday and really was blown away by their use of the POP grouper. And they had come up with some really amazing insights based on a neighborhood level drill down into the data, and felt that there was going to be some good action they could take on that, and was also wishing that they had the ability to overlay that data from the POP grouper to the attributed population. So looking at, is there a way that you could add a flag to a record in a POP grouper to say this is from OHT number 2, 5, 7, 15, whichever it is. And so there are questions that bubble up around what are the capabilities in that end. And additionally, there's also teams that are looking at recognizing that primary care is really the epicenter for action for a lot of sort of meeting the needs. How do we leverage EMR data to be able to look at the needs within that very local population that are accessing the care through that primary care practice, and sort of assess what services could be provided there. And understanding how that might be representative of the attributed population is, again, another tension that folks are holding. So we see people finding ways to move forward with local level data, and also acknowledging where they might have a gap in terms of understanding the overlap in the attributed data to the data that they have access to. The other thing that's emerged recently since the CQIPs, announcements of the CQIPs and the focus within them, is that there is an ability within the CQIPs and the consistency there in those 5 indicators to look at aligning work and understanding where the work that's already underway will align with those 5 indicators. And there's a question that is burbling up around what level of aggregation OHTs will be able to access data to take action in community. So for instance, will they be able to see data at the organizational level and to which end? Is there data that might be able to come forward at the level of a primary care practice to help them target action around who's doing well, who might need some support, and where to go from there. And I think the other question is around how you take some of the downstream indicators, such as first presentation in ED, and connect them to data within the community that can reflect more upstream efforts that folks would like to do, that looks at addressing people's needs earlier on, before they get to the point where they're in crisis in an ED. And so examples of what folks are doing and data that would be helpful from a process level is always welcome. And then thirdly, sort of the other thing that we're hearing is that a lot of OHTs understand conceptually the need to start moving down and working with those rising risk members of the population, or working on prevention and screening initiatives to look at keeping people healthy. And there's a desire to, one, look at examples of what folks have done to be able to do that effectively, and also understand how to leverage some of the different data sources that they have available to them to give them more insight into what are some of the needs in those sort of lower elements of the pyramid that target what they'd be able to assess. And I think, you see the conversation in the chat, there was some great conversation around frailty, and we're looking about how do we identify people that are frail. And it really brings back to that conversation around, if we want to look at early intervention, one of the things we have to do is look at consistent screening within primary care to identify frailty so that we can intervene earlier. And I know in talking to OHTs just this week that those are also conversations that are happening around how do we start building in consistent processes so we can identify people early when the data doesn't necessarily exist in some of those admin databases. So I'm going to end with that. And acknowledge that I think some of the presentations we have coming up by OHTs in just a moment are going to give some really fantastic insight to this. And I'd love to hear what others think, things that I've missed from the OHT perspective that are key for you, but also from the panelists, some thoughts you have on some of those challenges and realities and questions from the OHTs.
Yeah. So thanks, Rob, for the intro and summary. And Christina, I think, thanks for bringing the voice. And I'd look to the chat to see the extent to which people feel that the questions and points being raised by Christina are representative across OHTs. Certainly the coaches are in working with many, but not all of the OHTs. And so knowing what your challenges are, what your questions are around this, I think would be super helpful. We're going to go ahead and hear from a few more OHTs. This is a sort of OHT voice part. And then we'll come back to broad discussion. In the meantime, I do ask, and we'll maybe talk about opinions on some of those questions that you ask. And in the meantime, we're going to hear from 2 OHTs and hear about their experience. And I'll call this experience on the front lines. And first, Curtis Hanford, who has joined us now. I welcome you, Curtis, to share from the downtown east, because you had looked at some of the data packages that came, but you didn't stop there. And so if you could share maybe now how your OHT thought about including other sources of information and knowledge about pop health.
Yeah, thanks, Walter, and hi, everybody. I'm Curtis Hanford. I'm a family physician with the St. Mike's Academic Family Health Team, and have been involved with the Downtown East Toronto, Ontario Health Team from the get-go. I'm currently the chair of the what we call the Mental Health and Addictions Year 1 Population Working Group. Also one of the co-leads of the Downtown East Toronto Family Physician Network. So, happy to be here, and it might be disappointing for some of you, but perhaps encouraging to others that what I have to share is not particularly sophisticated. It really is an example of an Ontario Health Team partners trying to work this out on the front lines. I thought that was a very apt way of putting it. Our Downtown East Toronto Ontario Health Team very early on recognized for year 1, we wanted to focus on 2 main populations. One is people experiencing homelessness, and the other is adults with mental health symptoms who would benefit from counseling or psychotherapy in addition to or instead of medication. And these were individuals who what we started to call mild to moderate illness. So non-psychotic symptoms, not requiring referral to psychiatry, and not requiring intensive case management. And we knew from our engagement with primary care providers in particular over the years of the Toronto Central and Primary Care Strategy that access to counseling and psychotherapy, timely access to those services was a significant barrier for the care of people in the population. And we knew from our attributed data that actually Downtown East Toronto was disproportionately impacted by mental health and addictions right across the spectrum, but including the more highly prevalent symptoms and diagnoses, in particular depression and anxiety. So we were able to glean that from our OHTs attributed population data. And we also knew from some City of Toronto projections that Downtown East Toronto was going to be the area of the city with the largest population growth over the next 10 years. And so those 2 things combined led us to believe, you know what, we could probably start to work on a sizable chunk of our population if we focus in on this particular area for year 1, this adults with highly prevalent mental health and addictions concerns who are in need of counseling or psychotherapy. And so we've got a great work group that is comprised of family health teams, CHCs, community-based family physicians, psychiatrists, both hospital-based and community-based, community mental health providers. We have patients and community members engaged at different levels. And so quite a good group of about 20 or so partners at this point. And one of the things we did early on is we decided we needed to get some formal, I use the term data loosely, but some input from stakeholders in the community. So this included 3 groups: primary care providers, counseling and psychotherapy providers, and also clients and patients. And so we developed 3 different surveys that were very similar, but slightly unique, looking to see what are the services that people are already either using or referring people to. What are the needs that are the highest from the perception of the providers, but also the clients themselves. And then an opportunity for people to speak into what they think some priorities should be for an Ontario Health Team. And there was some reassuring overlap between the 3 different groups. On the client side, our partner organizations were able to help get the survey distributed to their contacts, their clients. So it is a skewed sample in the sense that it's individuals that are already tied into service provider organizations. And we got about 75 responses in I think a 2-week period. And we learned several interesting things, but one of the things that we learned that was really interesting is that one of the questions we asked was from a list of different conditions, what were the issues that clients felt were the most important for which to seek counseling and psychotherapy, or where the need was the greatest for counseling psychotherapy services. And depression and anxiety were significantly higher than most of the other listed concerns. And so we had already suspected that from the attributed population data, but hearing that one piece of the client voice into the equation and helped to affirm our focus on people with mild to moderate depression and anxiety symptoms, and helping to create a streamlined process, a stepped care model in our OAT for people to access counseling psychotherapy services with depression and anxiety. So that has sort of helped us to structure the rest of our work for year one, and it's just been one more piece of information, one more piece of data that aligned with the other data points that we had that we felt provided some affirmation of our direction and gave us some opportunities to reflect on the way we wanted to focus for year one. So I think that was my 5 minutes, and I certainly don't want to go over, but I'm happy to fill in any. I've left lots of gaps, but happy to answer any questions if it would be helpful to anyone.
Yeah, and so I'll just ask you, Curtis, to stick around, and we're just going to let Alex go, and then we'll come back to a discussion around this topic. Welcome, Alex, and I'll bring back up the screen so you have a chance to share your inputs from patients and families from the Western Middlesex London Ontario Health team.
Great, thanks, Walter. So today really just wanted to share some of our experience from the Western OHT and how we're approaching care pathway development through co-design. And in particular, really wanted to focus on the qualitative information that we've been getting from some of our co-design work. So this slide just outlines our overall approach to how we're co-designing patient care pathways. And I'll just call attention to a few pieces. So we are starting with COPD and CHF right now, and are currently exploring adding mental health and addiction as a third priority population. So because we have all of these different diagnostic groups that we're trying to develop care pathways for, we're trying to be very, develop a standard methodology for how we go about this related to care pathway and co-design. So you'll see in these steps that we have co-design embedded in just about every step that we're taking for developing care pathways. So starting from step one, we have patient and caregiver representation on our advisory committee for care pathway development. In step two, when we're looking at existing knowledge sources, we're not just looking at things like clinical practice guidelines, but we're also asking around for system partners to share any kind of co-design findings they have or patient experience data that they have that we can start to integrate into our planning. And then step three is where we really get into our real heavy co-design. So over the course of the past several months, we've been connecting with patients, caregivers, providers, one-on-one for interviews to really capture current experiences in the system and start to identify any opportunities for improvement. And we've analyzed all of those findings into key themes that now we're integrating into our care pathway development. And then the rest of the steps will just kind of validate the themes that we're hearing, validate some of the clinical practice guideline materials through Delphi methodology. And we're also looking at simulating this pathway as well for capacity planning purposes. And then on the next slide, just wanted to highlight our segmentation approach. And we're taking a little bit of a different direction in terms of segmentation. So we're focusing more on states of disease progression within each pathway. So we've bucketed patients within, for example, a COPD pathway into 6 states of progression. So starting from no risk, at risk, and then going through assessment and diagnosis, and then ending up in short-term, long-term, or emergency or exacerbation management. So the reason that we took this approach, one is that it should be relatively consistent across the different diagnostic groups. So as we have COPD and CHF laid out, the overall architecture will be the same across those groups, which means we can compare a lot more easily and integrate. And then the idea is that that green circle at the beginning, or that starting point, is always going to be our entire attributed population. So looking at a COPD pathway, for example, we know that we have roughly 7,000 COPD patients, probably a bit more. But when we start the COPD pathway, we're going to be starting with our whole attributed population of 525,000 people. Most of them will be in a no risk or at risk group. But the reason that we're doing that is that we can then guarantee that everybody in our attributed population is actively being managed on each pathway, and we know where they fit. And then on the next slide, just quickly, I'll highlight some of the different qualitative themes that we've been hearing about. So we're taking a fairly formal qualitative research methodology and analyzing some of the co-design findings that we've been hearing. So as I mentioned, we've been doing one-on-one interviews. We're transcribing those interviews, coding them, and starting to pull them into key themes. So over the last several months, the interviews that we've had have been analyzed into those 9 themes you'll see on the left. A lot of those will likely be consistent across many of the OHTs on this call. And now within each of those themes or buckets, we're starting to pull out some of the different activities that can be recommended based on those themes. So a couple I'll just point out. So one of the themes we heard a lot about from patients and caregivers is that caregivers are sometimes left out of care planning and their needs aren't always considered or evaluated. And that seemed to be exacerbated during the COVID pandemic. So one of the activities that's been translated out of that is the need for a caregiver screen that we're providing to any patients with caregivers. Another example we heard a lot about is related to goals of care. So when we were talking with patients, we'd hear a lot of goals of care that didn't always necessarily align with the traditional kind of clinical focused goal of care. So the action or activity that's recommended out of that is doing a goals of care assessment. So we're starting to build in some of these themes that are not necessarily included in all of the practice guidelines. So we're using this to capture a lot more social determinants of health needs and activities that can help support patients, caregivers, and providers. And now we're validating that through Delphi methodology, and we'll be forming some working groups to develop some solutions around these as well. So that's a really quick overview of the approach we're taking. And I do have my contact information if anybody wants to connect to go through it in a bit more detail.
Yeah, thank you. And so also, Alex, ask you to definitely stick around. Christina's chatted in. She loves that you're including goals of care, as do I. And I don't know if my colleague, Dr. Carolyn Steele-Gray, is online today or not, but you have lots of encouragement from us to think about goals of care. I'm going to just come back to the audience now with one other poll, and then it's our last poll, and then we're going to come back to some of these questions that people have raised. We have a few minutes left, which is fantastic. So I'm interested in where your OHT is at in terms of thinking about risk segmentation overall, and where you're headed on this. So here's our last poll. So where is your OHT at in terms of thinking about or using segmentation and define your overall population? This kind of gets at Rob and Christina's, and a little bit about how you're doing. You're just using whatever data you can find. We're talking about it. Still a little ways away, and I'm encouraged that we're an hour and 20 minutes into this, and we still have over 150 people still online. So I know we've definitely captured people's attention here today. Also because sometimes people only have an hour, like get scheduled in 1 hour blocks. Okay, I am fewer people responding this time. And so I'm just going to share back the results quickly. So some people just trying to use the data, other people having discussed it, but not undertaken the work, but it's on the radar. So I think, most people this is on the radar for people, even though they may not have completely advanced it so far yet. And the last question I'm going to lead off, and this is for OHT members or others that are working out there. I'm really interested in, Curtis and Alex have talked about using survey and qualitative data from populations to help set priorities or the interventions to meet the needs. And it's that finding, what is the level of risk, right? I mean, Curtis saying like this, actually, these were the services that people needed most. That's kind of around that risk aspect. And Alex talking about, building in and the essence, and that doesn't really come out of those big quantitative data sets that allow you to segment and risk stratify your population. So, and then any other questions for the panelists are also welcome. So I'm going to come back here, and I know that it'll be interesting, Ashnor's comment, to see how the participant goals align with the most expensive groupers and what some of those are. There was a question, and oh my goodness, there's been a lot of chat while I dialed into this part. Curtis, I think Christina had a question about whether you did look into your EMR snapshots at all, and looking at levels of need, if you were able to comment in on that. Can you comment on how you followed up with EMR snapshots?
Yes, for sure, and yeah, it also gives me an opportunity to thank Christina for helping us as our population health coach. I think I forgot that in the first 5 minutes. Yeah, this is again another example of really again sort of trying to do this right at the front line. So we have, as I mentioned at the beginning, we have community-based family physicians on our Ontario Health Team working group for this population, and we had already, in order to help guide the work, we had already heard a bit of a case series from one of them related to sort of the type of patient that he encountered in his practice that was really underserviced by the counseling and psychotherapy options that were out there, and so we sort of decided to take that the next step, and we asked our 2 community-based family physicians to just very informally go through and look at the billing data for a year to find out how many times they billed OHIP for the relevant billing codes for depression and anxiety, and recognizing that there's limitations to that. I think that's already been in the chat today, but and then we also had them follow their actual patient visits for a period of 1 or 2 weeks to determine what percentage of patients that they saw over a 2-week period that was having depression or anxiety symptom or diagnosis would have actually benefited from counseling or psychotherapy at that time had it been available to them. And in doing that, we were able to get sort of a bit of a rough estimate of, in a particular practice in a particular year, what's the number of patients that you might expect that would benefit from a referral to counseling psychotherapy. And then we were able to sort of, again, very roughly overlay that onto our attributed population downtown East Toronto. So it just gave us a bit of a sense in terms of what kinds of numbers we might be talking about in our entire attributed population. So I hope that made sense to everybody, but I think that's what you're trying to get me to get to, right, Christina? Okay. Thanks.
Great, thank you. I have another couple of comments to come back to actually from earlier, but be interesting if people have the other chats about, what are you doing out there in terms of more qualitative type information and sharing or gathering intelligence from your local providers. The one coming back, Christina, I think some of your questions, one of them thinking about how do we identify who belongs to our attributed population was one of the questions you'd asked, and I think other people may have other views. I would say, I'd be interested, Alex. You said you're working from 568,000 or whatever, 28,000, whichever it was. How you're thinking about actually wrapping your arms around all those people. Be very interested to hear if you have thoughts. I'd say for many OHTs right now, you sometimes have these broad population data sets with some information coming to you, either from the ministry or in other cases from HSPN. And I think the long run goal is you have direct access to that kind of information. I think in the short term, I'd say, think about at least focusing on getting your target populations, getting your arms around those focus populations and trying to get a registry or comprehensive set of data around those individuals. And then think about expanding outwards, and we'll try and help you with information, but that's where I'd start before you fully have. I don't know what other people thoughts they might have on that. Rob, I see you nodding.
Yeah, I agree with you, Walter. This is the tradecraft of population health management, and we're learning about the tradecraft on all of this. And so I think, our advice consistently with Christine and our coaches is to start with the data you have, with the format, with the view as to how do you fill in the data gaps in the future. So develop the tradecraft around the populations and then we will gradually fill in the gaps around the entire attributed population. I think we realize that you really can't manage an entire population without actually knowing who they are. And right now, you don't have access to the attributed population directly. But at the moment, I'm not sure that's a real problem because you're developing the tradecraft. There's no way that you could currently manage an entire population. So develop it, work on a data strategy, and I think that will be our recipe for moving forward, Walter.
Thanks for that. The last one that I think I'll just drop into, I'm conscious of our time, is the question around going upstream and connecting current indicators with CQIPs. And I think actually I wouldn't treat these differently. In fact, as you think about your CQIP indicators, think about how segmentation applies to understanding which patients have which needs that lead to those conditions and what the upstream solutions might be around. So if it's downstream mental health presentations in the emergency department, what are the capabilities of identifying those people before the emergency department? We had in a previous event on target populations, Paul Kurdiak talking about depression screening in primary care as being one of the ways of thinking about going a little bit more upstream, and then tracking that as an indicator. How many people have you screened? What is it turning up? And I know when we had our work looking at what they did in Northwest London in our previous Pop Health seminar, and also you can read it in our case summary, is they, in their primary care records, had PHQ-9s. And so they had primary care screening on all of their population, which they built into their custom segmentation. So I think lining things up in ways that make sense for you would probably be the best way to go. Conscious of time, I really want to thank our speakers today and answering in the audience. Again, come for the content, stay for the chat. It really is your contribution and engagement that makes this fun and interesting for everyone. Just to know, up next, we have started up again after a little hiatus in August. So our webinar series runs the fourth Tuesday of the month from 12 to 1:30 every month. You are always welcome. You'll get the notice on this one a little bit further ahead. It should be up by next week, along with the presentations from today and the video. October and November, we're going to take a little bit of a turn, and I think we like to have stories from OHTs along the way, but we're actually going to highlight this for October and November around some topics from some of the OHTs in the work that we're seeing happening. And it's really to generate conversations around these activities that we see as being representative of the types of work that OHTs are doing. So governance, many are working on that area of governance, some on strategic planning. Many are undertaking extensive patient and family caregiver engagement. So what does that look like in some cases? And people are just out doing things, local innovations. So we're going to be hearing from a couple of OHTs on each of the event dates. And we'll give our view of maybe what some of the spreadable pieces are on this. And given my role, I cannot but put this slide up just in case people are unaware of the North American Conference on Integrated Care that is happening next week, all week, hosted here in Toronto. Ideally, it would have been live, but we're going virtual. And I will say we've taken advantage, and we have panels and speakers that we could probably not have brought together in person. So have a look. And it is also patients included, co-designed with patients and caregivers. So I welcome you all to have a look and see if that's of interest to you. And particularly for OHTs, the ministry has made available a number of attendances for OHTs. So get in contact with your OHT lead contact for the ministry, and they'll be able to share any more information with you. Otherwise, take care. Have a lovely afternoon until we see you again. Thank you and goodbye.